Yadav, how many people you have trained?
Sir, 577 from India and
Wow.
around 52 from other countries. 10 years, every 6 monthly, we are taking around 5,200, fellows. 1 week training.
Okay.
It has been 10 years, yeah.
Very good.
So thank
very
you,
good.
but thank you. It is all blessings of Professor Atul Goel and Professor Dev Pujari sir. I learned from him and so many other neurosurgeon, and gradually I am doing. So it is all their blessings.
I can see Dr.
Thank you.
Dev Pujari has joined.
Good evening. Sorry,
evening.
got a little delayed in traveling. Welcome, Paul, and all our colleagues, Yadav, our host, Dr. Atul Goel, and Survendra. We have been doing these skull-based meetings once a year for now about 15 years, and though there is a lot of interest, the people who have actually come for short-term fellowships are about 40 so far. And surprisingly, there are more ENT surgeons. Well, not so surprisingly, I suppose. There are 30 of them are neurosurgeons and about 10 are 30 of them are ENT surgeons and 10 of them are neurosurgeons.
You think we should begin, Shekhar?
Yes, I think so. I'm sure Paul is going to surgery very soon.
Yes.
Paul, we are not going to leave you today, okay? You just better be.
I'll take you with me into the OR.
This meeting is essentially for me to learn from him and to discuss and to argue and to fight and ultimately bogs down to hugging. Okay. So Kishore, should we start, you think, Kishore?
Yes, sir. We can start it, sir. Actually, attendees has been joined the meeting, so we can start it right now, sir.
Okay, so there is, I have to introduce Paul Gardner. He's Professor Paul Gardner from Pittsburgh, and the place where I have been trained long time ago. So big memories go by whenever I talk about Pittsburgh. And Paul is one of the leading stars in teaching the whole world endoscopic neurosurgery. And many of you or most of you know him because he has conducted several workshops in India and in Asia and all over the place. So what I am impressed by Paul is, one is his innovative mind, and more importantly, his high technical skills, which I have seen personally, and one of the very fine technical endoscopic surgeons. And you agree, Shekhar, with that?
Absolutely.
Absolutely fine technical skills that he has demonstrated on several occasions to several people all over the world. So what the plan is that I will like Paul to deliver his lecture, and then I will put in several case scenarios and argue out my case with Paul and with other leading experts in endoscopy in our country, Dr. Shekhar Dev Pujari, Dr. Yadav, and Dr. Sarvinder Singh. So this is the plan. Sarvinder Singh or Sarvinder Rai?
Right.
So he is also one of the stars. And as you know, Paul, as you can imagine, as you know yourself, that to learn endoscopic work requires considerable hard work, dedicated work for a neurosurgeon to switch from cranial to endoscopy. And Dr. Sarvinder has demonstrated it to himself and to me that how hard work and dedication and persistence can, lead you to anywhere in the field of endoscopy and in any surgery for that matter. So without further ado, I will like Paul to take the center stage and show us all about, lead us towards endoscopic world of neurosurgery. Paul Gardner from University of Pittsburgh. Paul.
Thank you very much, Atul. It's very much an honor to be speaking here for you. I certainly look up to you very much as a master of skull-based surgery, and your legend preceded you even before I ever met you. But I would have never expected to be able to become such friends and colleagues. And Atul has taught me a lot in general, and his philosophies, I think, about surgery and about life, and about how surgery is a part of nature. As well as his questioning of things that we do has forced me to reevaluate some of the things I do and constantly learn. So it's very much an honor to be here speaking. I'm going to go through some of what I think are advantages and limitations. I will maybe skip through a little bit of the lecture because I do think it's important. The discussion that we want to have at the end of this, I think, is maybe the most important part. One of the perhaps key aspects of endoscopy is that an endoscope is different than a microscope. It has different optical properties. A microscope, I can look at this structure, I can zoom in on it, I can magnify it, I have a 3D view, but an endoscope can actually be placed into the surgical field. So a microscope can get larger and larger, but the endoscope can actually go into the surgical field to allow me to see things that I wouldn't be able to see normally. And so here's an example, an endoscope actually sitting in the actual field. And this is the view that I would get then in that same portico that we saw a picture of before. So it's taking advantage of putting this instrument that we can visualize into the field. And here is a view from a microscope with a speculum of the sella. And here's the same view with the endoscope. And it's simply by placing the endoscope into that field that we're taking advantage of all of the things, all of the view that it can provide. The endoscopic endonasal approach takes advantage of this by using both nostrils and by using the nasal cavities. We place an endoscope in the top of the right nostril, and then a suction in the same nostril and a working instrument on the other side. This is done really with two surgeons working side by side. This is one potential limitation. I think to be applied best, it does require team surgery like this. But as a neurosurgeon, I have different things I want to do. I want to see all the critical structures. I want to have good two-hand surgery, and I want to try to figure out how to keep the endoscope out of the way. At the same time, my ENT surgeon is trying to preserve anatomy and function, as well as worry about reconstruction. There's a whole set of modules of approaches, and we can access all the way from the cribriform and the frontal sinus, all the way down to the odontoid. Of course, all of this started in the sella. That's where this work was developed, as it began in the sella. And we begin to understand that because we can see more laterally with an endoscope, we can access things like cavernous sinus invasion. Here you see an acromegalic with a tumor here clearly invading into the cavernous sinus behind the carotid artery. And the key to this is exposing that artery so that we can mobilize it. So we remove the bone overlying it. Here's just removing the bone over the sella. But then here's the paracellar carotid artery. We need to thin and remove the bone over that artery as well. This is just like we would do with a lateral skull-based surgery where we expose the carotid on a petrosectomy, for example. But the ability to do this allows us to mobilize the carotid and go into the cavernous sinus. The medial portion of the cavernous sinus, remember, has no nerves in it. So we can access that entire medial portion and resect tumor from the medial cavernous sinus without any damage to the cranial nerves. Here we're Dopplering just to make sure we see, know where the cavernous carotid is, and then we'll open into the tumor. And you'll notice throughout, hopefully, these videos that we're always using microsurgical techniques. So this isn't blind pulling. This isn't using a curette like is done traditionally with pituitary surgery, but all of our surgery is done with microsurgical instruments. They're extended instruments. They're specially designed for this, but it's still microsurgery. So here I'm dissecting the tumor away from the carotid artery. Here we can see the carotid itself, and you can see how the tumor is adherent to the medial wall, and then dissecting it free from the gland. So there's often a nice pseudocapsule between a pituitary tumor and a gland. And now I want to debulk the tumor to give myself more room and get some specimen. But here you can see a nice clean boundary with the sella. And then here's the last bit of the medial cavernous wall being resected. I'm working behind the carotid. You can see how much we mobilize the carotid artery in order to be able to access. And here's the rest of the medial cavernous wall being resected. Again, I don't want to just pull it off of the artery, so those areas of attachments have to be sharply cut. Here we see the carotid artery. I've coagulated any remnant of the cavernous sinus, and the carotid is widely open, but I've been able to resect tumor from that cavernous sinus because I can see it and because I can mobilize the artery. This can also be extended upward to the tuberculum and the planum region, simply by opening up the ethmoid. Here's the kind of, again, wide surgical view that we get with the endoscope. I can see everything from the planum to the tuberculum. I can see the sella, the clival recess, the carotid and the optic. Here's the lateral OCR, and here's the area that we call the medial OCR. Again, this is like the keyhole for an endonasal craniotomy because it gives me access to the sella, the carotid, the optic, and the suprasellar space. Now, the bone removal we do for a tuberculum or a planum meningioma is really very wide. So it's not a narrow removal. It's this kind of very wide anterior removal, including making sure we remove that medial OCR. This allows me, when I open the dura, to have this beautiful view of the superior hypophyseal arteries, which are a very important microvasculature that I think we get a much better view from below, and one of the potential advantages of coming at this endonasally. So for these suprasellar approaches, important to have a very wide access, remove that medial OCR, expose the carotid at the diaphragma, and visualize the superior hypophyseal artery perforators. These give supply to the gland and to the chiasm, so they're very important for tumors in this region. And again, resection has to be microsurgical, using all the same concepts with internal debulking and extracapsular dissection. Now, retrochiasmatic tumors are one that are very well suited for this. You'll notice the stalk is always behind the chiasm, an important piece of anatomy to remember. So any tumor that arises from the chiasm, like a craniopharyngioma, or rather from the stalk, like a craniopharyngioma, is always going to be retrochiasmatic. Even when they billow in front of the chiasm, they still originate in the stalk, which makes them retrochiasmatic tumors. And I think an endonasal approach provides a very natural corridor in line for these tumors. We can get early stalk identification. We can preserve hypothalamic margin with a better view of that, but CSF leak is a limitation. If you look at the long corridor, the inline corridor of a craniopharyngioma, and the two-point concept where you want to choose your approach to be in line with this, the endonasal corridor is really the only one that gives us that access for craniopharyngioma. This is just looking at our more recent series up in 2017. We're able to get gross total resection in half, and then another half of those had near total resection. Again, a lot of that depends on the goal of surgery and the plane with the hypothalamus. We can get early stalk identification. So here's an example of a craniopharyngioma. Very difficult to tell where the stalk might be here. I'm going to fast forward this, but when we open in the suprasellar space, I can tell here that this is all just cyst wall. So there's no stalk there. I'm just seeing cyst wall. I can drain the cyst initially. Here's using indocyanine green endoscopy. We can help use that to identify vessels and identify vascular tissue. And we start to see a hint of the stalk here. You can see the microvasculature of the stalk. I can tell that this is tumor. So this direct view onto the tumor allows me to separate the two. I'm really seeing normal tissue here and the abnormal tumor off to the patient's left. I'm dissecting free the superior hypophyseal. Here you can see that hypophyseal coming directly away. And then I can debulk the tumor. And again, using microsurgery here to dissect the tumor all the way up to the hypothalamus, working with an angled endoscope to dissect it off of the floor of the third ventricle and the posterior wall of the chiasm. And here's the last bit on the floor of the third ventricle. Again, this is all done. This is not just blindly pulling the tumor down. It's all done under direct visualization with microsurgical dissection. This requires patience. It requires convincing yourself that you can do this with a microsurgical resection. But you really, if you can't keep those same concepts as you would doing this with an open microsurgical approach, then you're not going to have better outcomes, or certainly even the same outcomes as you would with an open approach. So here we see the last bit of attachment, and I can see here we've preserved the entire stalk and the attachment of the stalk at the tuberculum. There's the last bit of the attachment, and here's our final view. And I can decide if I want to preserve the stalk, if I want to resect it. In this case, I think it's okay to leave a little bit of this capsule to preserve pituitary function. And this woman, I was able to preserve her function. Here you can see the post-op. We have the stalk completely preserved. And not only is the stalk preserved, but its function is preserved. And here you can see able to maintain pituitary function in about a third of patients. This isn't perfect, but when we do preserve it, we give a chance for that perfect surgery where we're able to preserve function and get a complete removal. Same thing for diabetes insipidus, about 56% had new DI, but that means 45% did not. Finally, perhaps the most important is the hypothalamic margin. This is the thing that can lead to devastation of a patient. Here's a craniopharyngioma that's failed radiation, so it has probably a very poor margin with the hypothalamus. But again, a very wide exposure. We can see the margin with the hypothalamus. Now this tumor is going to be disconnected because the hypothalamus has to be dissected. But here you can see this, we can see the chiasm. I can see directly that margin with the hypothalamus, and I can decide how much I want to dissect it. Do I want to leave some tumor behind? Or do I want to be aggressive? Now this tumor has failed radiation, but you can visualize there that margin. There's no other approach that gives us this view of that margin with the floor of the hypothalamus. So we can debulk it and then go back and dissect that margin, be as aggressive or as conservative as we want to, depending on the patient's age and their function. You can see the stalk is going to be disconnected. But here I can make a decision that there's my line between normal and abnormal, and I can get a complete and gross total resection of this tumor. Vision is another thing that probably does better with an endoscopic approach from below. We had no permanent worsening, and 86% of patients had improved vision. Calcified tumors really are not a limitation. Here's a very calcified tumor that we did endonasally, and here I'm using an ultrasonic aspirator. I can drill this tumor, so you can see it's attached to the basilar. It doesn't matter which approach I use, this is going to be extremely challenging. I have to stabilize it and drill next to the basilar, so this is very sort of harrowing surgery to do. And of course, I'm not going to cure this tumor, but I think at the end, we're able to get a removal of the majority of the tumor on this multiply recurrent craniopharyngioma and not cause any new deficits. Well, what is a limitation? Well, the floor of the third ventricle is one limitation. If you have a tumor that's growing from the ventricle down, you'll see this here, it pushes the floor of the third down. So we have an acute angle here between the floor of the third. Here, a typical tumor grows from the stalk or grows from the tuber cinereum and pushes the floor up. So we have an obtuse angle. This means the tumor is growing below the floor of the third, and I would do this from an endonasal approach. Here, where it's growing from the third and pushing the floor down, I would do from a craniotomy. So this is I did through a translamina terminalis approach, and we're able to get a complete resection. CSF leak does remain a limitation though, and I think I've discussed this many times with the tool. You have to have follow-up for 2 or 3 weeks after surgery with these patients, because that's the risk period for CSF leak. And if they can't come back reliably, that's a problem. Suprasellar meningiomas, here's a view of a meningioma from above and incidentally discovered during an autopsy on a patient. And here you can see how the relationship of the tumor to the chiasm. So inherently the tumor is growing from below. So we're simply following the tumor and its pattern of growth by coming through the nose. So here's a typical meningioma. Again, you'll notice a very, very wide exposure that we'll take here. And an important piece is that as we're moving this bone, you can see that the dura itself is involved. So this wide resection of the tuberculum and planum dura is what helps us get a more complete removal. We can do a Simpson grade 1 removal because we're resecting all of the involved dura. I'm also not just pulling the tumor out. This is also not a very soft and suctionable tumor. It's a fibrous tumor, so I have to cut it into small pieces. I have to internally debulk it and then do extracapsular dissection. Again, very careful microsurgical technique here, not just reaching in and pulling the tumor out. This is tedious surgery. It does take time, but I think the rewards are worth it. You have to understand what the anatomy is around the tumor because we don't see the anatomy first because we're landing directly on the tumor. So we'll find one optic. We'll need to be careful to look up at the anterior cerebrals. And then working with an angled endoscope, I can start to look out towards the optic canal. Here I'm dissecting the other optic. This has a reasonable arachnoid plane. Debulking the tumor some more. And then finally peeling the last bit, and you can see how this is attached on the medial aspect of the optic canal. I'm not just peeling this off of the dura, but I'm going to resect that dura completely to get a Simpson grade 1 resection. I'll look out with an angled endoscope, looking into the medial optic canal. And here's our final view. You can see all of the dura has been resected right up to the dural ring. We've preserved the anterior cerebrals. We've preserved the superior hypophyseal branches and able to get a complete removal. Not just complete, but a Simpson grade 1 resection. And then we do a multi-layer reconstruction with nasal septal flap. And here's the post-op showing complete removal and improvement in vision. I think these are the advantages. We get early devascularization and lower Simpson grade, and it may provide visual outcome advantages. I'll skip through this somewhat in the interest of time, but you'll see here vision loss is the primary presenting. And in our suprasellar meningiomas, we were able to get Simpson grade 1 resection in almost 80% of cases, and most of the rest had near total. There may be better visual outcomes. We only had visual deterioration in 2 patients, 4%. If you compare that to most modern craniotomy studies in the literature, it is a lower rate, and most of the literature agrees with this improved vision outcomes. What about lateral extension? What about optic canal invasion? Well, most of these tumors invade into the medial canal. Certainly if they come over the top of the optic, they can be less accessible. But by doing a wide decompression of the optic canal and removing the bone over the optic canal, we can access all the way out into the optic canal and get a much wider resection. So optic canal location was not a limitation for us for gross total resection. Vascular encasement and very large tumors with a poor arachnoid plane were factors. I think this could affect perhaps any approach, but there's no question that vascular dissection may be more difficult and is higher along in the learning curve. So certainly a tumor with no vascular involvement is really very straightforward. But as soon as there's contact with the ACA, you have to be comfortable doing a microsurgical dissection. And if there's encasement, it becomes that much more challenging. Here's a case with encasement where I injured the A2 and the artery of Heubner, and the patient had a caudate infarct as a part of the resection. So this risk goes up dramatically, and your ability to do microsurgical dissection has to improve over time. Here you can see our gross total resection rates improving over time, getting better and better. There's a clear learning curve with this surgery. Part of that learning curve is understanding this wide extent of bony removal. Wide bony removal means wider intradural dissection. CSF leak remains a limitation. Here you can see we dropped it with the flap down to 16%, and now we're down to around 8%, but still a higher rate of CSF leak than from a craniotomy. We also avoid brain exposure and manipulation. We had no patients with seizures, no cerebral contusions, no hemorrhage. We don't treat them with any seizure medication, so this seems to be an advantage. The transcribiform approach is perhaps even more controversial, extending more to tumors like an olfactory groove meningioma. Philosophically, the only thing that I will say, there is only a certain size that you can access. There is a size limitation, but it has some of the same advantages as tuberculum. Now, if I showed you this meningioma, no one would question that you would want to access this tumor from its base, and the base of this tumor is on the convexity. This is the same tumor, just turned upside down. The natural thing to do is to not come at it from the side, but to come at the base of the tumor. Any other meningioma in any other location, everyone would say this is the natural approach to it. So coming through the cribriform, through the ethmoidal sinuses, we can do early devascularization of the tumor, and we can get a better Simpson grade resection. We can see the posterior margin better. We can visualize the optic canals better. Here you see the view from below. And again, I won't spend too much time on this, but from some of the larger tumors, we did have to stage, but able to get Simpson grade 1 resection in 2/3 of patients with olfactory groove meningiomas. Here you can see a very large tumor with a lot of edema. So we did 1 stage, the tumor collapsed down, and we were actually able to remove the whole tumor in the 2nd stage. You can see though, larger tumors, we had lower rates of gross total resection. And again, that calcification and involvement of the anterior cerebrals limit our resection. This is looking at more recently 100 meningiomas everywhere from the olfactory all the way back to the tuberculum, and looking at locations of residual or recurrence. And this is very useful because you can see the lateral half of the orbit. We can remove the lamina papricia and retract the orbit to gain access to the medial half of the orbit. But we can't get access to the lateral optic canal. I cannot access the anterior clinoid, and I can only go so far up the falx coming through the nose. So these really are the limitations. They're anatomic limitations of the approach. And if you have a tumor extending to these areas that you want to completely remove, this is not the approach for that. So these are those limitations for an endonasal approach. We don't want to cross the nerve, so the clinoid, anterior clinoidal tumors like this, or encasement of the carotid, these are cases clearly I would do open. And these are cases that I would do endonasally because they're medially oriented and medially originating. And then there are some cases that I think are challenging no matter what approach you take. Here's an interesting case we did recently where this tumor is really billowing out, but it's not attaching. It's just billowing out to the side. It's pushing the optic nerve up. And I was actually able to follow the tumor out all the way over the top of the carotid. The tumor had gone all the way out to the ICA bifurcation. And here's our final view after a complete resection of this tumor. So the tumor creates the corridor in some of these cases. And here's the post-op with a complete removal of this tumor, despite the fact that it was going out over the carotid artery. There are still high rates of CSF leak with olfactory groove. Again, we have this down to about 10%, but the limitation is we have to resect the dura. So we do a Simpson grade 1 resection. With an open craniotomy, I don't have to create that skull base defect, but I can potentially leave a whole, I can leave tumor behind in that case if I don't resect the skull base. Our leak rates have decreased over time, and we do avoid brain manipulation. We don't have the same seizure risk. We looked at this on MRI, and we could see less change in the frontal lobe after endonasal surgery than after craniotomy. So this may potentially have cognitive effects long-term if we preserve frontal lobe function better. Also, much lower rates of seizures, 1% as opposed to 3% with craniotomy for similar types of tumors. The transclival approach is one of the more direct approaches and one of the more widely accepted approaches. It's a very direct midline approach, access to the entire clivus. So tumors like this chordoma, this is a very natural access. I can remove all of the involved bone. I can remove all of the involved tumor, and I can resect all of the involved dura. So I can get a true radical removal of this chordoma, not just scooping it out, but removing everything involved around it. And this provides, I think, better outcomes for something like a clival chordoma. Again, we're able to achieve complete removal now in 90% of our primary tumors. We looked at this recently. But for complete removal of chordoma, even in our own series, 11% of patients required an open approach. So endonasal surgery cannot be used alone in any particular kind of tumor. We had lower rates of cranial nerve palsy, only 5% new 6 nerve palsies and primary tumors. So this compares very favorably to other series. We cannot, so when we start working inferior and lateral, especially behind the carotid artery, this becomes a limitation. And you see there at the bottom, years of experience. So there's a very clear learning curve. We published our own learning curve. Here's over our first 60 patients, very clear learning curve with endonasal surgery for chordoma. One of the areas we began to understand better is below foramen lacerum, we have much wider access to this entire inferior and lateral area. We can access the condyle. We can access a tumor like this that goes all the way out to the hypoglossal canal. We can get a very wide resection of the tumor. Here we've drilled all the way out to the inferior petrosal sinus. So I can pack off the inferior petrosal sinus, but this gives me a very, very wide resection. I'm coming all the way out to the hypoglossal canal here. So you can see the hypoglossal canal on both sides. I've drilled out the jugular tubercle. I've drilled out the condyle. And then we can resect dura. So all the way out to both hypoglossal canals and both condyles without destabilizing this patient and getting a very radical removal of all involved bone, all involved dura. We can access tumors like this epidermoid tumor. You can see how this is pressing into the brainstem. There's no other good approach to access this. So this very direct approach allows me to dissect tumor even directly out of the brainstem next to the basilar. Here's teasing that tumor right next to the basilar out of the pons. If I leave that behind, it's going to keep growing into the pons and eventually cause significant new problems, new symptoms, and it won't be treatable if we leave that behind. Here's our final view where we're able to get a complete resection of certainly all of the contents of the cyst, but probably obviously not all of the cyst wall. I think in this location, that's basically impossible to get a complete resection of all of the cyst wall. Certainly a higher risk of CSF leak in the posterior fossa. You can see our leak rate about 23%. We've again got that down to about 10%, but still the posterior fossa is a challenge. I'll skip this probably in the interest of time. And also I think Dr. Goel has taught me a lot about basilar invagination. More and more, especially in younger patients, if they have basilar invagination, we do the Goel technique. Many of our patients, Atul, are patients with degenerative arthritis and not traditional basilar invagination. But when they have basilar invagination now, I prefer to do to reduce their subluxation in the way that Atul taught me. We can resect the odontoid and do a fusion in situ, but again, when possible, you should try to do a reduction. There are advantages over doing this transorally, though. They can be fed immediately. They don't have the same risk of issues with their palate. And again, here is our learning curve for odontoid, with the length of surgery decreasing dramatically to now it only taking us about 2 to 3 hours, where at first it could take us 7 to 8 hours. What about vascular control? Where here's a giant aneurysm. And again, I think probably even in my hands, this is a very scary case. But this does demonstrate that we can use aneurysm clips. We do have vascular control. This is a very large atherosclerotic, very heavy aneurysm. I can't just place a clip directly on it. It's just too heavy, has too much force behind it. So here I'll place temporary clips on the basilar and on the P1. And then this allows me to decompress the aneurysm. I can then place an initial clip, remove my temporary clips, and now I can replace bolster clips now to get a complete clipping of this. I can see the third nerve to decompress it. I can see the perforators to preserve those. I don't want this too tight because look how much atherosclerosis there is in that vessel. It will shut down the SCA if I place that too tight. And there's our final view. And there's our final angiogram with obliteration of the aneurysm and preservation of the vessels. Here's a case though where we had carotid injury. We had done a neck exposure for carotid control. But once I did actually injure the carotid, I had no choice but just to sacrifice it because I couldn't suture. So this is certainly a limitation, is carotid control in these situations. Fortunately, the child had good collateral and there was no stroke from this. Here you can see our rate of carotid injury. It has persisted at about this level, and you can see chordomas or chondroid tumors are the biggest risk. And most of the time we sacrifice the artery. We're not able to preserve it many times. Fortunately, most patients can tolerate loss of the carotid. Suturing is a key limitation. And I think for me, it has been very important to have a good endovascular colleague to help save me in times when I have a vascular injury. Here is our injury algorithm. Essentially, if it's a small injury, then we'll try to preserve it, coagulate it, or clip it. If it's a large injury, though, often we have to just pack it off or sacrifice it. Of course, there are anatomic limitations. Here we can see the nerves and the orbit, and of course, reaching the inferior limits of the odontoid and the anterior limits of the posterior sinus. These are the simple and anatomic limitations. A CSF leak is reconstruction limitation. Certainly it depends. You have to be able to have multi-layer reconstruction. We tried everything, suturing, etc. And then finally, we use buttresses, like a balloon. All of this helped, but what finally made the biggest difference was vascularized reconstruction. You really need vascularized reconstruction for skull-base reconstruction. This was true for open surgery until the pericranial flap was developed. The leak rates were astronomically high. And the same thing is true for nasal septal flap. Here is me with my our friends and saviors, Drs. Haddad and Basagastagi, who came up with this flap that we now employ that really, I think, saved endonasal surgery. This nasal septal flap has made a huge difference. You can see the leak rate now down to less than 5% for pituitaries, 3%. Low rates of meningitis, lowering rates for meningiomas, for chordoma. Here you see the leak rates in craniopharyngioma. It's now less than 8% for all of our cases with intradural, not all cases, but all cases where we have a high flow leak. Here you can see our continued learning curve. We track this every month. We track it every year. You can see in 2019, we were down to around 6%. It stays somewhere in the 6 to 7% range. And this is maybe one of the most important things about this. I've tried to show there's a learning curve. It's both technical and it's anatomic, and this learning curve has to be respected. Here you can see meningiomas, slowly increasing the number of endonasal. You can see the complexity done at our institution in the first 10 years. You can see the black line at the bottom were the most complex cases. For the first 5 years, there were none of these cases even done. You have to be very slow and careful about applying these techniques. This is what we believe to be perhaps the levels for an endoscopic skull-based surgeon. You can see level 2 and 3 are things like pituitary or extradural skull-based surgery, perhaps extradural chordomas or odontoids. And only when we get to intradural skull-based surgery, that's when we go to level 4 and 5. Many people don't believe in crossing that barrier, and I think that there's some truth to that unless you're willing to really dedicate to the learning curve for everything from reconstruction to dissection. And then finally, level 5 is probably the most controversial and certainly the highest risk. If you look at this, if you look at our levels 4 and 5, this is looking at different things: blood loss, duration of surgery. If you look at the green and the purple, those are levels 4 and 5. That's where the risks go up dramatically. And that's where we have to really start to reconsider how committed we are to doing those particular approaches. Coming back to the main principles, though, I need bimanual exposure. My resection has to be microsurgical, or I won't have the same results. And my reconstruction has to be a multi-layer vascularized reconstruction. Finally, the corridor and the particular tumor depends. What are the patient's goals? And what is my own surgical experience? All of these should factor in. These were developed as a result of cross-fertilization, and I believe it's best applied by a multi-specialty team between rhinology, head and neck surgery, pituitary, skull base, and cerebrovascular. this all together forms an endoscopic surgeon. We're still trying to understand, where does endonasal surgery fall? Craniotomy is clearly the standard of care. Endonasal is trying to find places where it fits in as the standard of care. Of course, I always invite everyone to our course. We may be holding some virtual courses later this year or early next year, and certainly would love to see you in Pittsburgh once we can all travel again. In the meantime, this is a free educational website. I invite everyone to join. There's no charge to this. It's designed as an interactive, there's a blog on there. We place cases and ask for people's input. It's designed as a community. We invite you to contribute cases for all of us who do skull-based surgery to have a discussion and review anatomy, et cetera. So it's all on there. And again, I want to thank Dr. Goel for the time today, and it's an honor to be here. Thank you.
Thank you, Paul, for this fantastic presentation and taking us around the world of endoscopic neurosurgery. Can you unshare your screen, Paul?
Of course, yeah.
Yeah. So what I'm going to do is, I have with me an international expert, Paul Gardner, who, he has given his point of view. And I was recently more amazed when he was showing petroclival meningiomas, and he was operating on petroclival. Somehow he didn't show all those things, but I'm sure it is quite an intriguing, and maybe he himself thinks that it is a little bit too much. But he was showing, and he was showing some fantastic corridors as to how to go behind using the corridor of foramen lacerum and how to enter into that area, and the various triangles he was showing. That was absolute fascination and really a new world. So we have Paul Gardner with us. We have Shekhar Devpujari. If you know Paul, he was the president of International Society of Pediatric Neurosurgery, and he is conducting several workshops and taking your message and other people's message and his own personal message to the world, and teaching us how to do endoscopic work. And he's one of the stars of Indian neurosurgery without any question, one of the most famous and one of the most loved neurosurgeons. We have another very prominent and very loved neurosurgeon, Dr. Yadav, with us, Paul, today. And his shows on endoscopic, you have already seen the number of people he has trained, more than 500 from India, and about 100 from outside the country. Dr. Yadav is also, proponent and quite a big man, big name at least. I'm not sure about how famous he is but he also done phenomenal work in endoscopic neurosurgery. The third and is my personal, I don't know how to say, but he's Sarvendra Rai. He works with me, and I have seen him personally, how much he has dedicated and how much hard work in cadavers. He has bought his own endoscope because we were not very, happy with endoscopic work. So he bought his own endoscope and he worked in cadavers there. Very fantastic hard work. And that is what I learned from him. And he's going to give his opinion on various strategies. So now what my plan is, let me see. I'm going to take you to various pathologies and I will first like to show my own work, and then I will have comments from the experts on the panel. So the issue is nose or head. And I must tell you that nose is also my favorite territory and head is also my favorite world. So let us see when I use nose and when I use head, and where I do not like nose and where I do not like head. So these are the issues. So my first case, which I'm going to show you, is this one. This case is I did in 1991, so about 30 years ago. This is, as you know, This is one of the most benign tumors of the body and one of the most vascular tumors of the body. This is cavernous hemangioma of cavernous sinus. In 1991, first I entered through the nose, and as soon as I entered through the nose into the tumor, there was such a big blood loss that I had to, we had gone, this tumor was not known at that time. Hardly 50 cases were actually reported throughout the world. Dr. Shekhar had compiled the series, and only 50 patients were identified in the world in 1991 or 1992. Because MRI was not in existence at that time, so this tumor was considered identified as pituitary tumor by me. Enter, bleeding, severe bleeding, backed out. Report came as cavernous hemangioma. And then I did transcranial operation with all fronto-orbitozygomatic osteotomies and things like that. And I removed this tumor in 1991. And this was amongst the very few tumors reported with pre-op and post-operative picture. There were hardly any cases reported before this. Then I analyzed more and more cases as they came to me. Today, my experience is 39 cases, which is one of the, the largest series in the world. And what we have realized, this cavernous hemangiomas are entirely intracavernous sinus tumor. They displace the lateral wall. They have intercellular extension. They never transgress the dural boundary. They never transgress the dural boundary. They go towards the orbit. They go towards the Meckel's cave. So completely intracavernous sinus tumor. Internal carotid artery is encased by the tumor. Sixth nerve is encased by the tumor. Nerves of the lateral wall are displaced by the tumor. So this is the anatomy of cavernous hemangioma of cavernous sinus. No matter how big the tumor becomes, intercellular extension towards the Meckel cave, towards the orbit, lateral dural wall displaced. So this is completely within the dural confines of cavernous sinus. Most vascular tumor bleeds. So in the year 2000, I described 13 cases, and we identified that cavernous sinus is an extradural entity, and extradural approach was the best. So first time in the literature, we described extradural approach to these tumors. At that time, 13 cases. Now, as I mentioned, 39 cases. So extradural approach to tumors was first described in this article. Of course, cavernous sinus vascular lesions were described much before by Vinko Dollens, but tumors, you see the PubMed, there is no report before that. Of course, for trigeminal neurinoma report was there, but not for intracavernous sinus tumor. And then we have several cases like this. This patient came with third nerve palsy, and I will like Paul to answer this question, what will be his approach for this tumor? And I did, as I mentioned, extradural approach. And just to show in the surgical, just a minute. What happened here? So just to take you on video of this case, extradural exposure, the nerves of the trigeminal nerve are exposed extradurally, middle meningeal artery is coagulated and cut. Very vascular tumor. Even when you are not near the tumor, it bleeds. So you identify the whole lateral wall, V1, V2, V3 nerves you identify, and they will be depicted here. And then work within between the trigeminal nerves, between the laterally displaced trigeminal nerves. The trick of trade is, in these cases, is to come between the cranial nerves. And then the first thing that you have to do is identify and separate off the sixth cranial nerve. Unless you identify and separate off the sixth cranial bleeding situation, quite considerable bleeding. This is the V2, this is the V1. First, I tried between the V2 and V1, and then I went between the V1 and the third and fourth nerve complex, like the Parkinson's triangle. Quite a bleeding situation, but you know what? You have to, as you know, you have to just continue. Extensive coagulation may not be the best way to do it. First and foremost, try to identify, not try to, you have to identify. You see, here is the sixth nerve. I have gone to the pectus apex, identified and isolated the sixth nerve. And then I work around the tumor as much as possible and remove this tumor. Most important thing is, with my experience, I can tell you that this, number one, is this will bleed quite furiously. That is one. Second thing is, this will bleed furiously from the lateral infralateral trunk of the carotid artery. Sometimes from the meningohypophyseal trunk, but infralateral trunk is the most common, and the carotid artery will bleed. During the separation, I have kept this, shown this case because there was a carotid artery bleed in this case, and I want to ask Paul as to what will be his strategy in such a case in cavernous hemangioma in general, and particularly because my feeling is that it will bleed furiously. That is one problem. And second problem is to identify the sixth nerve from a transnasal route will be quite a challenging affair. That is number two thing. And the third thing is to handle the bleeding from carotid artery will be another challenging aspect from the nasal route. And bleeding from carotid artery in my cases, there was a small rupture near the infralateral trunk, which is not very difficult to handle from a transcranial route. So here is the, you will see the carotid artery very soon. And I am basically using right-handed dissection. This is the carotid artery. And it is now, here it is actually bleeding. You will see. And then I put some pressure over it and little bit coagulation. And then you see, this is the tumor which I am holding in my hand. Now, as soon as the cavernous sinus is released, there will be venous bleeding. And then you have to pack off with the gel foam and whatever you have to pack off. But you see, here is the carotid artery bleeding. Now, you see here, and carotid artery will bleed. Then you have the carotid right in front of your nose. And then you can actually, it is a small near the lateral trunk, lateral to your exposure if you are coming from the nose. And then you have to, and sometimes you have to take a small stitch because the artery is right in front there. You can do proximal clipping, distal clipping, coagulate that point under vision, or take a one single stitch and that's the matter closed. So this tumor, which is quite a hugely benign tumor, and the situation is that you can cure this person. The other thing is you don't have, radiation will not work here. And I will ask the panel as to what your strategy will be in this situation. And whether you will take the risk of transnasal surgery in this situation of a tumor which is entirely within the cavernous sinus, which is a hugely vascular tumor, and the issues which I have discussed. Now here you see all the cranial nerves are under my vision. The third and fourth nerve complex is within the dura, which is away from the surgical field. You don't have to expose the third and fourth nerve. They are inside, intradural in their course. And the entire surgery can be done and the control of bleeding can be done under direct vision. So I will just go a little bit ahead in the story. And this, ultimately, the bleeding control is not such a difficult job here. And the thing has stopped. So this is preoperative. You see the third nerve weakness. And within 3 months, the third nerve has completely recovered and you can see the smile on the face. Another tumor, you see cavernous hemangioma encasing the carotid lateral wall intact with an aneurysm. This, of course, is a rare situation. You never try to come from the nose. You come laterally, and this I had operated 25 years ago, this case, and I had clipped this. This is immediate post-op. You see there is a lot of, this is not temporal brain retraction or something. The tumor itself was such a huge tumor. You see the tumor itself was a huge tumor. And I have no further follow-up. This patient is absolutely fine. So now, Paul and the panel, I want you to give your opinion on this cavernous hemangioma as an entity and your attitude on this tumor. Paul first, and then the other experts. Paul.
I think it depends a little bit on the
Paul,
size.
Unmute.
I think, can you hear me okay?
Paul, unmute.
I think I am, it shows me as
we
unmuted.
cannot hear you, Paul.
Yeah, I'm seeing myself unmuted, but
No.
Can anybody else hear me?
Wait.
Yes, we can hear you well.
Sorry, am I? Okay, Paul, go ahead.
A tool muted me.
Yeah, sorry.
So I think it depends on how lateral the tumor extends. Some of these very giant ones that you've shown would be very challenging endonasally, but I think an important thing that you see in your video is that this is a tumor that originates in the medial cavernous sinus, and it pushes all of the nerves lateral. And so because of that, I follow the tumor. I do have to dissect the carotid artery. We have to mobilize and completely visualize it, coagulate any attachments. I agree, infralateral trunk and meningohypophyseal are the two main. And you do have to be able to deal with that, but we do have bipolar for that. But the beauty of it is that I don't have to work between the nerves. I can simply dissect the tumor free. It spreads the carotid artery apart. It pushes the nerves laterally. So I just follow the tumor through its corridor and I can get a resection in that way. I haven't done nearly the number that you have. I've only done a handful of these, but I've done them after other surgeons have failed from an open surgery. And I find that because they start in the medial cavernous sinus, all I have to deal with is the carotid artery.
What about bleeding? What about bleeding situation? How you handle the bleeding?
They're the same way. I mean, it's no different. It's no different than the way you handle it. I use a bipolar. I keep my suction constantly active, coagulate the tumor, try to get outside the tumor rather than dissecting inside it. This is one tumor that I try to stay outside the capsule, but the carotid artery dissection is the difficult part. I coagulate and I dissect it. It's no different, but I have to be able to do that bimanual dissection to do it.
So what we have seen is, Paul, yes, Shekhar, what is your opinion?
No, I haven't actually tackled any cavernous hemangioma of the cavernous sinus by endonasal approach for the fear of bleeding, and whatever experience I have, about half a dozen cases, is all extradural cavernous sinus transcranial approach. So I won't be able to comment on the endonasal approach being used for this, but it's quite logical from what Paul is saying. And I think most of the times people who have not been able to get the complete excision, you will find most of the residuals are the medially left behind tumors. And I'm pretty sure that it is possible. It certainly would depend on your level of experience, and I can imagine that it can be done quite well if you are not so much worried about bleeding, but I have no personal experience.
Dr. Yadav, you are around?
Sir.
Yes.
Sir.
Yeah. Have you done any cavernous hemangioma?
I have not done it, sir. But I think looking at the, the pictures and the course, since it is arising from medial side and pushing the nerve laterally, so can be done with the experience. I have not done it and I will not try also because I think if you make some complications like injury to the carotid. To me, I feel that unless you have endovascular people, risking the patient is not advisable. So, but with the experience, not the person who has started initial surgery, then possibly from transnasal it can be done. And obviously, as the person of your caliber, you can do anything from lateral or medial. But I mean, practically, I think when it is coming from medial side, it is better to come from transnasal because you will come across the tumor first rather than the nerve from lateral side. So theoretical comments, sir.
Yes,
No experience.
Professor Sarvinder Kumar, what is your opinion?
Essentially, the size of the tumor is too big, and secondly, the vascularity of this tumor is profuse. So bleeding would be a serious risk, and if we go endonasally, means we need a really good team who has a good experience in dealing with this kind of situation. But it was definitely not for a novice, means for a person done a few cases to handle such a vascular tumor in the first instance. So it would be possible to exercise with good team and with some kind of experience. But these lesions, what you showed was too large a size to be handled through the endonasal route, because any bleeding situation would be too difficult to handle, and they were too lateral to be excised completely via endonasal route.
Yeah, I
So
agree.
in any case, I think open would be more preferable in less experienced hand.
No, you know, you said it correctly that such lateral exposure, Paul, such lateral exposure, how much you said that such lateral I will not go. What is your limit of lateral? This is what Professor Sarvinder Singh said.
Yeah, I mean, I think there's a certain point when it's when it's almost touching the temporal bone that it doesn't make sense. But the truth is that the tumor is pushing the carotid laterally. And as long as the tumor is opening that corridor, I'm comfortable reaching. I would say it is the most, if it comes very anterior and lateral, then it becomes very difficult. You can actually go sublabial on the contralateral side to extend your lateral access.
So this was, Paul, we described extradural approach several years ago, and most people who are doing transcranial surgery use extradural approach. So you'll be happy to hear that. Okay, so now I will go to the next entity which I want to discuss with you is tuberculum.
Just real quickly, I will still be here. I'm just going to turn off my video for a second. I just need to check something, but I will still be here.
So I should go on with this?
Yes, please do.
You have a video of a cavernous hemangioma, Paul?
I do. It's a small one. It's a very small one compared to tools. I was trying to find, I have another large one, but I can't find the video for it.
We can see that, Paul. You just quickly come back. I'll wait for you if you want.
I think you have to turn off your shared screen, Atul, for me to show it.
What we can do is, Paul, if you want to show it now, you can show, or you show. Go ahead.
Let me just show real quickly. This is a relatively small one. Here, can you see that okay?
Yeah.
So it's relatively small, but again, we've exposed not just the sella, but also the entire carotid artery on this side. Right. And so here's dissecting the carotid free from the tumor. So this is the dissection of the carotid, and we have to be able to coagulate. But you see it, you can visualize the plane. It does bleed a lot, but I'm able to deal with that. I didn't know what this was, so sort of debulking it, which wasn't the best idea, rather probably would have been to coagulate it or peel it. But as soon as it's free from the carotid, I can completely peel it out of the cavernous sinus. And the sixth nerve gets displaced downward by these. So it grows from the medial cavernous, it pushes the sixth nerve downward. So here the first step is just completely dissecting it free from the carotid. Once it's free from the carotid, then I can just peel its capsule and it becomes extracapsular surgery here. So here I'm just peeling it backwards behind. It goes into the genu of the carotid. It goes back into the genu.
The other
So here
thing,
you can see.
Paul, to identify lateral to the carotid is not so difficult, huh?
Well, because the tumor opens up the genu, because the tumor spreads the genu of the carotid, we can go through that what we call the superior compartment of the medial cavernous sinus and follow that all the way out. And that's going back towards the posterior clinoid. It's eroded the posterior clinoid, but we're behind the carotid now. So here's the carotid. There's the sixth nerve that again gets pushed down, and we're behind the carotid. I said I do have a larger one that I couldn't find the video of right quickly, but this is an older video of a smaller one. And then just peeling the last bits of it off the diaphragma. But again, I don't ever see the nerves because the lateral cavernous is pushed out. So that's the lateral cavernous wall there. So it's the nerve itself is not exposed because it's ensheathed in the two layers. And here's the post-op with a complete removal and a collapse of that cavernous. But I've even done, chondrosarcomas, other tumors in exactly that location. So I think it's doable, but I think there's a certain size, and this is level 4 or level 5 because we're dissecting the carotid. So I agree that this certainly is not something that should be done without a lot of experience.
Most important, Paul, is to identify before operation that it is indeed a cavernous hemangioma. You see, these parameters were not available earlier. This parameter were not there. This radiological, how do you identify cavernous hemangioma from pituitary? These parameters have never been described. So what you saw, that lateral wall is displaced, carotid is extending towards intercellular compartment, towards orbit. These are very characteristic and constant. So these features can give you a direction as to what is this tumor, okay? So we go now to the next pathology, which is also very heavily debated pathology. And tuberculum meningiomas and olfactory groove meningioma. So in 2002, I described 70 cases of tuberculum meningiomas. And the most important thing is now we have nearly 300 cases, which is the largest series in the world. And also olfactory groove meningioma, this is the largest in the world. And in the year 2000, I showed 60 cases of anterior clinoid meningioma. You can imagine. So this is a very chronic. Essentially, what I'm trying to show is that tuberculum meningiomas are not, they are different. You see, they can extend anteriorly right, having a very large anterior base. And it doesn't end here. It goes on, if you see from above, the tuberculum meningioma, there can be small granules here. It is not that this is the end of the story here. And this presence of tumor, small dural attachments here, are almost 100% and constant. So tuberculum rapidly to go through tuberculum they can be small, they can be medium sized, they can be huge. They can have a very wide basal attachment. They can be near the pituitary or away from the pituitary. You see here also the anterior skull base, there is some enhancement. This enhancement is because there is tumor. You cannot remove from here and not remove this part of the tumor. Sometimes the tumor is closer to the, and you see these are the ones which are, maybe the only ones in my estimation quite easily amenable from transnasal. Lateral extension is difficult, as we heard. Calcific, you see these kind of calcifications can be there. And encasement of anterior cerebral artery may be a big question mark for transnasal surgery. Encasement of internal carotid artery may be also a question mark. Such calcification may indeed be a question mark. Such extensive edema can be a question mark. Graded suprasellar meningiomas according to clinical parameters and radiological parameters. And I don't want to go too much, but these are most wonderful tumors to operate from the transcranial route. You come and you remove these tumors. Many of these tumors are very soft tumors. Some are a little bit hard tumors, some are a little bit more hard tumors, but the plane of dissection is beautiful. You just debulk you come from here, start debulking the tumor. You can reach the tumor in good 5 minutes and start debulking and then dissect. Most dangerous part of this operation is the identification of anterior cerebral artery and its branches. You damage one perforator, you damage the person very badly. So my estimation will be to get first identify the anterior cerebral artery, isolate it, and then do the dissection. Debulk, isolate the anterior cerebral artery, dissect it away, and then do the rest of the dissection. That will be my strategy of surgery. When anterior cerebral artery is encased, you can, these tumors are softer tumors when such encasement is there. Visual deficit is one big parameter. So all my cases we have done from the head, and all the cases have been, you see, there have been problems, and there have been, which I have published on several occasions. Going lateral is one issue which can be a dramatic issue in endoscopic surgery. Firm and calcific tumor can be another dramatic issue. These kind of larger tumors can be with calcification. This tumor was removed in very quick time. This is another large tumor. Whether you will like to come from here, my strategy is start debulking. You see here there is necrosis. Break into the tumor, identify and separate the anterior cerebral artery and its branches, and then debulk the tumor, and then handle the anterior skull base, handle the optic canal circumferentially. So there are tremendous advantages of a transcranial route. You see, there is no need to remove all this bone and go and transgress the dura and subject this person for CSF leakages. The tumors which are right bang in the midline are much more easier tumors, and many of these tumors can be removed in very quick time. I don't want to stress too much of time, but maybe in 15-20 minutes you can remove that kind of tumor, this calcific tumor. I am not sure what approach. This is one tumor which may be a good tumor for trans, but you see, still nobody knows as to how this vessel, how the anterior cerebral will be attached, and how much you will have to dissect and further resect. So these are my issues with tuberculum meningioma. Just I don't want to show this. Everybody knows how to remove a tuberculum meningioma. So this is, you see, transcranial. Open the sylvian fissure. This is the frontal root. Identify the tumor and then start debulking the tumor. You see, right in front of your nose, you debulk the tumor, separate it from the base, and then identify one cranial nerve. You see, this is softish tumor. More often than not, this is the consistency of tumor. The anterior cerebral artery branches, and then go on dissecting and removing. You will not believe that in my nearing 300 cases, I have never damaged pituitary stalk. There is such a beautiful plane of dissection and arachnoid layer with the pituitary stalk. I have damaged and harmed, and also some of my patients have died. I'm not saying I don't want to give, because much of my work is published. These anterior cerebral artery branches are very, very dangerous. I cannot, it will be very difficult for me to imagine how you can dissect and save and then resect the tumor between the cranial, between the I can imagine properties of the panelists, and of course with Paul Gardner and Shekhar and Dr. Yadav and Professor Sarvinder, you can remove these tumors, but you can have difficulty and you can have very serious, you see the optic nerve, how badly it have that vision. So those are my points, and I want to put the question to the panel. Paul is not, Paul, you are not there at present. So Paul, you have seen my questions which I raised during my dissection. So please answer. The other thing, Paul, you said and you compared the series of transcranial and transnasal. You yourself said that I will select the midline ones, I will select the ones which are not encasing the anterior cerebral artery, and I will do transcranial for those. So obviously transcranial surgery has been done for more difficult tumors. So it is not absolutely correct to compare these two groups. This is my understanding. Answer from Paul Gardner. Yes.
So I do all tuberculum and planum meningiomas endonasally, but my point was that if there are anterior cerebral involvement, that those are more difficult and many people would not do them that way. But for me, I do them endonasally. The only limit, in fact, if someone presents with vision loss, even if the tumor extends, for example, to the anterior clinoid, I will still do it endonasally, but tell them there's going to be a small amount left that I might have to go from an open surgery later. So I would argue that my case series does not have a selection bias. Now, there are very, very large planum meningiomas that extend very laterally. So it's not necessarily size or complexity of the tumor, but if there's a dramatic lateral extension, then that would be a limitation for me. But I do think that there are better visual outcomes with an endonasal approach because I'm coming onto the tumor and I don't have to work around the optic nerve. I don't have to manipulate the optic. I just take the tumor away from it. So I do think that, that's the advantage.
My question is, how do you handle the anterior cerebral artery and the perforators?
Well, I think that I need to find it where I find the A1 where it comes over the top of the optic nerve, and then I follow it towards the ACOM. I have to be able to slowly and carefully dissect it. I can show videos of that. It's absolutely one of the most challenging things to do, but it is possible. Again, it's farther along in the learning curve.
Dr. Dev Pujari.
Well, I would say a few comments, actually, Atul. Whatever you said for transcranial approach, actually all of that applies to endonasal approach. You get a beautiful corridor. You must have seen in your own collection of cases which you showed today. You will find one of the things which almost always seen is that the sphenoid sinus is much bigger when you have a tuberculum cellae or a planum meningioma. And most of the time you can find that your sinus reaches the anterior margin of the tumor. Second thing is, what you said is you can take out more tumor, granular tissue, etc. I think you are taking out all the involved bone, you are taking out all the involved dura in an endonasal approach, unlike just coagulating it in a transcranial approach. And if you are saying that you are excising the dura, or if you are extensively sort of peeling it off, then what you are left with is also a CSF leak, even if you do a transcranial approach, because you might end up in ethmoid sinus or sphenoid sinus. So I think, to me, earlier, I always thought cortical cuff, which is a thing which Paul said and Amin Kasam always sort of emphasized. But it seems that cortical cuff probably also not be so important from what the New York group and others have written, and some of the dissection which Paul has shown today. Like what he showed in the cavernous sinus, you know, anterior cerebral artery, when we say it is encased, what we are talking about is that many a times it is displaced. Like he showed in the cavernous meningioma, you can see that there is a corridor from the genu, you can find somewhere. So similarly, the anterior cerebral is not only, it is open somewhere and you find some corridor to, you know, peel off the tumor from the vessel. And we have about 15 cases now, not a very large, because we are more selective. And the second reason, Paul, we cannot do that is most people do not accept a second surgery, either for financial reasons or for accessibility to a center where it can be easily done. And therefore, whenever somebody says ki nahi, ek operation mein, I mean, you have to do everything in one operation, then you have to tell them. I think one of the reasons which may favor a transcranial approach is probably your chances of saving olfaction are a little better. And that was the question
I was going to ask Paul as to what is their experience with saving olfaction in these meningiomas. And of course, tumor going over carotid artery, sometimes you can even take that tumor out. But I think anything going lateral to the optic nerve becomes becomes a difficult thing. You can do a beautiful optic canal decompression. You can do more than 180 degrees of optic canal removal and take out the tumor from there.
Dr. Yadav, I will ask
Sir.
Paul to answer the questions that about olfaction later after Dr. Yadav and Professor Sarvinder. Yeah.
Sir, I have little experience. I have done 4 or 5 cases, but I do only small meningiomas, tuberculum cellum meningiomas, which are less than 3 centimeter. And obviously, if the dural tail or the tumor goes lateral to the optic nerve or the artery, then I don't. I prefer the cranial approach. But reading the literature says that the visual outcome, there can be question that when you take the transcranial approach, then possibly these tumors are larger. So comparing these two approaches may not be correct way, because for larger tumor you go for intracranial approach, for a smaller you go for this thing. But for me, smaller tumor lateral to medial to this thing. But most of these, I agree that most of them, the dural attachment, even if the tumor is very large, dural attachment is in between these two optic nerves. So it can be done, but I think the dural tail and these things are difficult. And once the vessel are encased, then for me it becomes difficult. So I don't venture when the tumor is large, only for small lesions.
Yes, Professor Sarvinder.
Yes, I would probably give a good. I will look the radiology, give more important to radiology, because I would definitely like to handle such cases endonasally only when the tumor size is small and the dural tailing should be sufficiently of such size to be able to remove endonasally. Otherwise, if we are not able to take out the dural tail and the remnant and able to give Simpson grade 0, then I wouldn't try to venture out endonasally. And of course, I agree with Professor Yadav and Dr. Paul that if other things like vascular encasement and all, then definitely transcranial.
You know what, Paul, my experience now is nearing 300 cases of tuberculum suprasellar meningiomas. And I'm absolutely convinced it is such a beautiful operation from the head. Beautiful and tremendous, arachnoidal dissection of the arteries away, getting, there is no limitation at all, no limitation. There is, tumor hidden optic nerve, tumor hidden carotid artery encased, anterior cerebral artery encased. More than that, you can avoid all the nasal work that is, not without, as he said about olfaction. To have all this nasal work for a tumor, which can be quite easily, I'm not contesting you, of course, one is familiar, becomes more and more familiar, and with your kind of expertise, you don't think. But what I'm telling you from my experience of last 32 or 33 years with 300 cases, that I am absolutely convinced that will be my approach, and I do not want to change. There are other places where I have changed, and I will discuss with you. So answer quickly these questions and we go on to the next pathology.
Olfaction, obviously I think that the risk is higher endonasally, but I think for tuberculum and planum, it is pretty low. It's maybe 5 to 10%, but there's no question that it's lower with a craniotomy. The only thing I would disagree with is I do think there are areas that are limited through a craniotomy. The ipsilateral optic nerve, the medial optic canal on the ipsilateral side, you cannot see it. The tuberculum going down into the sella, any bony involvement of the tuberculum and planum, those generally are not addressed through a craniotomy approach. So just like the clinoid, I can't reach from an endonasal approach, the medial optic canal and the tuberculum and the diaphragma and even the sella can't be addressed from a craniotomy approach. So I think they both have their limitations. And I think you have to choose based on the specific patient, which is more important to them.
Okay.
If I have a patient with a planum meningioma, I will tell them that their risk of loss of olfaction is a little higher, but I don't have to touch their brain, or I don't have to, and they have a little better chance for vision, and I will let them choose. And I've had patients choose a craniotomy in that setting. So I think you have to be honest with your patient.
I think, you know what, I can understand about olfaction and other things, but I think comparing vision is a little bit overkill, my dear Paul. I think we should not compare, because transcranial also gives a beautiful access to the optic nerve early in the operation. You can do the tumor removal under vision, and I don't see any reason at all as to why the vision will be better preserved by the nasal route rather than cranial route. And my feeling is, you see, I've never done endonasal for tuberculum celli, but I don't see any reason why endonasal should be better than transcranial. Okay, so discussion ends here. We go to the next subject. Okay, Paul, you're ready for the next attack?
You have any comment on just cortical cuff?
On what, I'm sorry?
Do you have a comment on cortical cuff? Do you still think that is important? Because if you're operating on patients with encased anterior cerebral, etc., you're obviously not considering that as a factor anymore.
Yeah, I only bring that up because I think it's very important for people learning to take that into account. I know it's going to be more difficult if there's no cortical cuff, but a vascular encasement does not change my mind about approach.
Right.
For me, I still do it endonasally.
Okay, now, Paul, we go to a very important tumor where I will say endonasal route has a very fantastic opportunity to remove, and that is clival chordomas. So these are clival chordomas. To just show you how the clival chordomas behave. See, clival chordomas are tumors which demolish the bone and displace the soft tissues. They displace the carotid artery anteriorly, very constant, and this is the diagnostic. They are essentially extradural tumors, and they displace the cavernous sinus superiorly. So this is what description I gave in 1993 or 1994. You see, carotid artery is displaced, and these tumors are extradural. So you can imagine the tumor location. Even in chondrosarcomas like this, the carotid artery is displaced anteriorly. And this was one of my I am very happy with this and proud of this article, which I wrote in 1995, that carotid artery is anterior, cavernous sinus cranial nerves are superior, and the sixth nerve is also superior, which I will talk to you after a little while. So the carotid artery is here, and the sixth nerve goes on the dome of the tumor. So there is such a huge space between the sixth nerve, the fifth nerve, the third nerve, and the lateral aspect. There is no carotid artery here. So we had described a very fascinating approach in 1995, so 25 years ago. Middle fossa, come from the middle fossa. There will be no carotid artery in your picture, which is anterior. You can actually hold the carotid artery in vision. The cranial nerves are displaced laterally, the bone is destroyed, and lateral view is a good, beautiful operation, these extradural tumors. So this is what we had described in 1995. Of course, we have changed. So even this tumor, which is essentially intracranial, the diagnostic thing was the destruction of part of clivus, which is not seen here, and the displacement, anterior displacement of the carotid artery. And we had done transcranial route, middle fossa, and believe me, this tumor was done in very, very quick time. And the dura was preserved during operation, and that was the defining thing. So recently I have, now what I will say is, there are some cases which go in the midline and which go exactly in the sphenoid sinus and go a little bit lateral into the region of cavernous sinus. But you must imagine that cavernous relationship are not a regular pituitary type relationship. These are unusual relationships. And I will agree if Paul says that I will like to do all chordomas by the nose. I will agree and I will not contest, but one must remember that to have a control of carotid artery under vision is very safe from a transcranial route, and then to identify the sixth nerve and to save the sixth nerve is quite better from a transcranial route. But what I'm going to show is a very unusual route, which we have recently published, supracerebellar route to clavicle chordomas. You see this tumor coming right behind in the cerebellum. You can come from the nose, but the distance here can become quite tremendously big. So we had used extradural supracerebellar approach. I identified the sixth nerve quite early in the operation, and then debulked in this direction and debulked in this direction from the brain. So I had to cut the dura once here and once here. So 2 dural cuts, and then I removed this tumor. So this was a supracerebellar. Sixth nerve, of course, was lost before the operation, remained lost after the operation, but anatomically preserved during the operation. This is another tumor. One can contest that this is a clavicle chordoma. I will like to come from the nose, but there is another option to save the sixth nerve, which goes on the dome of the tumor. I think that is a very crucial point, which may be a little bit difficult. Of course, this tumor I will not contest if you say that I will remove it transnasal. This is another tumor which I may not contest. I will remove it, but I removed it transcranial and supracerebellar. This is unusual. These are the only 5 cases we have done in our history of chordomas. Majority we have done from transcranial middle fossa approach, and some cases recently we have done with Dr. Sarvendra Kumar, Professor Singh, by transnasal route. But this is my view. Now I want to show you one case and I want to have your opinion. Now this is a solid hard rock crystal tumor involving the cavernous sinus, and we know that this is a chondrosarcoma. There is no argument about it, but I have shown you already that chondrosarcoma will displace the carotid artery anteriorly. That is one issue, and it will displace the cranial nerves on the dome of the tumor. So this is a dramatic tumor, and I would like to have your opinion. And this is you see, this is completely solid bone and rock-like bone. And just few video clips, I did it transcranial, of course, because you see, this is a very classical approach and I don't want to spend too much time, but I will like to show you how the things went. And carotid artery was saved early, procured and protected early in the operation, anterior to the tumor. This is tumor where all kind of drills and all kinds of solid instrument. There was not a single soft component like we have in several chondrosarcomas. This was all solid rock bone, and you can imagine this tumor being removed from the nose. I am sure it can be. I know there is. I will not even argue if you say I will remove it from the nose, but to have the complete control on carotid artery, which can be. If somebody says there is no danger to carotid artery, I'm sure Paul will not say. I'm sure 100% he will not say there is no danger to the carotid artery. But, to have a control on carotid artery, you see, this is complete, I am using all bone instruments. And, I am showing some better parts of the operation. And here is the carotid artery anteriorly, you see, in my vision. Not clearly seen in these images, but it was, and then I go along the tumor and very solid crystal bone, which was drilled and which was removed in pieces. As you can imagine, this is the drill which I'm using. And you have to be, you have to be completely in control of the various cranial nerves and direction of the surgery. And I will like to have your opinion as to, you see, some parts are removed. There's still several parts of the tumor remaining. And this was the multiple tumors, and this was small bits still remaining. And for your opinion on chordomas, Paul. Over to you, Paul.
I mean, I think obviously chordoma is one of the main tumors that this has provided a dramatic corridor for. Even the ones that grow and compress the brainstem often are growing between the two layers of dura, and the inner meningeal layer is being stretched like a diaphragma. And the tumor itself creates a very wide corridor. So that's one issue. The other issue is seeding. Any approach you take with a chordoma, you have to be worried about seeding that corridor. We've certainly seen it endonasally. It happens about 1.5% of the time in very aggressive tumors. But the nasal seeds, I think, potentially are easier to deal with. We also use sheaths in the nose to try to prevent that. I think the two issues that you talked about, carotid injury, absolutely, they're the highest risk of any tumor. 3% as opposed to 0.3%, so 10 times greater risk of carotid injury. And if you're going to do an extensive chordoma removal, you have to be prepared to deal with the carotid artery. I agree with you completely on that. You have to be comfortable with that.
What about chondrosarcomas?
Chondrosarcoma, same issue. It's the same issue. I think chondrosarcoma is good for endonasal. I think I can drill it. I can do all the same things. I can show you a calcified cavernous chondrosarcoma that we had to literally drill into pieces to remove it. It's the same issues, but you have to be comfortable with the carotid with whichever approach you choose. A chondrosarcoma that tends to extend into the petrous apex or the petroclival junction, we've gone now to using not just endonasal, but we call a contralateral transmaxillary approach, where we come sublabial on the opposite side, and that puts us in direct line with the petrous carotid artery. So that's a nice sort of newer approach that Dr. Schneiderman came up with that allows us even a little more lateral access to resect those tumors. But chondrosarcomas and chordomas, both of them, we sometimes do have to use complete a craniotomy. They are not ones that you can always just do endonasally. There's no question about that.
Shekhar?
I think endonasal approach is very good for chordomas because of the sound principle that you are basically dealing with a extradural tumor. And I think to do a completely intradural approach for that, and to do a posterior approach for an anteriorly placed tumor does not really appeal to me. So since, and I'm sure Atul, that if you are doing a transsphenoidal microscopic approach I'm sure in your hands also you would have had good results. The only reason you are not able to do it is because of the speculum, and therefore your range of vision decreases considerably. I think chordoma is, according to me, a very good indication, and next to pituitary and retrochiasmal craniopharyngioma, I think this is probably an ideal indication. It is also a good tumor because you can suck out a lot of tumor and you can drill out a little bone a little better. You can find the interface a little better. I have not used the contralateral approach, though we have used transmaxillary approach for the lower clival tumors. We have not gone beyond the lateral suture. And this is one reason why we have sometimes used a combined approach. On the other hand, I have a little, suboptimal kind of a satisfactory work with chondrosarcomas, because I find that chondrosarcomas cannot be debulked so easily. And therefore, when you are drilling, you are likely to manipulate the vessels much more. And therefore, I think there is a little more caution required while dealing with chondrosarcomas. We have now about 42 chordomas and about 7 or 8 chondrosarcomas. And we find it quite a good approach.
You know what, Paul, I agree completely that for chordomas, extradural tumor, extradural approach is the best. I agree, and I raise my hands. But for a chondrosarcoma of the kind which I showed, I think it is highly dangerous to have that kind of chondrosarcoma removed from the nose, because if the carotid artery, which can be very dangerously poised in this situation of chondrosarcoma, if it ruptures, you have very, very little chance of, on the other hand, as I've shown, that carotid is continuously in my control during a transcranial route. That is my advantage, you see, and carotid artery in such a chondrosarcoma can be tremendous. Okay, I will take your, I wish you can, both Shekhar and Paul, Paul, you can get one chondrosarcoma. I will like to see your video, and Shekhar at the end of all the cases which I show. And also Shekhar, I want to see a chordoma by endoscopic if you can manage to hunt it. Professor Sarvinder, what is your opinion on chordomas? You have seen, we have done. And I must also tell you, Shekhar, with Sarvinder now becoming more and more senior and more accomplished, I don't give him too much opportunities because of my passion of another kind, but he's becoming slowly and surely a power to reckon with. I'm sure, you see, I'm not using artificial words. He's becoming a power to reckon with
Very
in
happy
the future.
to know that. Very happy to know that.
Just give few words, Sarvinder, about chordomas. And
But I agree with Professor Dev Pujari, and but the last lesion what you showed, you had removed transcranial, that I think endoscopically it would be very difficult. It's not, I don't see there would be much room for manipulation and such kind of extensive manipulation around that region with such a limited corridor.
Paul, your last few words, so we move on to the next pathology.
I mean, I agree. I think that your ability to manage the carotid is better from an open approach, but I do think you can visualize, and I think you can, again, take advantage of the tumor corridor in many of these to do a chondrosarcoma. I do have videos if you want to see them, obviously.
Yes,
but,
after a while. Okay. Yeah. Now, what I want to take you is another tumor, which is, there is no argument about that tumor, that this tumor, giant pituitary tumors and pituitary. I have kept it just to introduce, Paul, to my classification, which you were asking me. One of these days you were, in meetings, you were asking me about the classification. So I want to show you my classification, and also, and this is also my strategy towards pituitary tumors. And you will be happy to know that my strategy will be transnasal surgery in 100% of cases. I will never do transcranial in 100% of cases. So I want to just take you around with my classification of giant pituitary tumors. This was long time ago, about maybe 18 or 19 years ago. We published this, and there are several publications on this subject and various books and book chapters I have written about this. And so these are giant pituitary tumors. What we had said is these giants are real giants, but there is a method in this madness. So what we did was, for the first time, Paul, you will be surprised and you will be happy to learn, for the first time in the literature, we described that the diaphragm celli dura is elevated by the tumor. In this tumor, the general impression is that it goes subarachnoid and all those things. If it goes subarachnoid, then you have to, when I described this 20 years ago, all these cases were done transcranial. But our description of dura, that the tumor is under the diaphragm, has completely revolutionized pituitary tumor surgery according to my understanding. So you can clearly see the dura getting elevated. This concept was not there 20 years ago, and these kind of tumors were all done transcranial. Even these kind of nubbins, this is of course not subarachnoid. This is a dura is protecting this tumor. This kind of nubbin, the dura is there. So that makes the transnasal surgery with this dural protection a very viable option. You see, it is going in the brainstem, all right, but there is dura. If you understand this concept, you can remove this tumor. So grade 2 was in my classification when the tumor enters into the cavernous sinus. See, the lateral wall is elevated, but the tumor remains within the cavernous sinus when the carotid artery is encased. The diaphragm celli is intact. Diaphragm is intact. Both cavernous sinuses are involved by the tumor. So this classification, dura is elevated. Now dura is stretched. Dura of the lateral wall is stretched. This is inside the cavernous sinus. This is under the diaphragm, under the dura. Now here you see the dura of the diaphragm is elevated. Dura of the roof of cavernous sinus is elevated. This is the first time in the literature we said that this is under the dura. Now I will show you. This is under the diaphragm, under the dural roof of cavernous sinus. You can clearly see that the dural roof of the cavernous sinus is elevated. This is under the diaphragm. This is dural roof, diaphragm, dural roof. These slides, and it is very rare that the tumor will encase the arteries of circle of Willis. This is grade 4. I call it an aggressive malignant pituitary tumor. So this is my classification. Grade 1, when the diaphragm is elevated, not going in cavernous sinus, even the tumor can touch the convexity, but it is having no vessel within the tumor. Grade 2 is when it goes in the cavernous sinus. Grade 3 is when the dural roof is elevated, and these are very common types of pituitary tumor. Grade 4 is when the arteries of anterior circulation are encased by the tumor. And this concept of diaphragm, I think this is a revolution in pituitary tumor surgery without any doubt in my mind. And these tumors, which were 20 years ago, 25 years ago, all transcranial were done. Just remove the anterior wall. No need to remove planum sphenoidale, tuberculum celli, anterior wall, debulk the tumor, and the whole diaphragm will ultimately land into picture in good 15-20 minutes. And this was done 23 years ago. And this is my concept, that the diaphragm is like uterus and transvaginal delivery is the best surgical route for these tumors. And these tumors now I have got several, nearing 5,000 cases of pituitary tumors, which we have reported and published. And there is no question, whether you use endoscope or whether you use microscope, that is a very little of a controversy. Believe me, I don't use endoscope, but I don't think I need endoscope for these tumors. Even the tumor which is going in subfrontal, they were classically removed by transcranial. I will say, if you have endoscope, good. But if you don't have endoscope, if you have the concept that the diaphragm is going to be intact, then you can remove this tumor. Even this kind of tumor, you don't need to remove. You have 30 degree, 60 degree, 90 degree, whichever degree you have. But if you have 100% concept of the diaphragm, you can remove this tumor with any kind. You see this tumor I removed 20 years ago with microscope, and I still will like to use microscope because I'm comfortable. Whether you use endoscope or microscope, that is very little issue. The concept of diaphragm, if you have, you can remove several of these tumors. In 1999, you see this diaphragm, with this concept, I removed this tumor. Cavernous sinus extension also can be done with microscope or endoscope or whatever you have to use, but that is different. But if you have the concept of dural walls of cavernous sinus, if you have the concept of dural roof of the cavernous sinus, then the whole thing becomes a different game. You see, if you have the concept that this tumor is under the roof of cavernous sinus, and this tumor, this third nerve will be a little bit complex issue to be explained, and then you can remove this tumor in a very beautiful manner. This tumor, whether you remove transcranial or whether you remove transnasal, is going to be a danger issue in both these routes. Comments from Paul and the panelist. Comment, Paul.
I think those are some of the most important concepts. Understanding what the tumor has done to normal structures, I think, is everything for any tumor. And I think that's absolutely brilliant classification. I think it completely hits the most important points. You know, understanding that the tumor can expand into the oculomotor triangle, for example, and lift up the roof of the cavernous sinus, and just following the route that the tumor took is, I couldn't agree more. I love the analogy of a transvaginal delivery. If it's okay, I will steal that idea. I will give you credit, but it's absolutely brilliant. You're absolutely correct about that. The only question I would bring up is, or the difficulty when I think you really need a wide exposure in the transplanum, for example, is for very fibrous tumors. Maybe 5 to 10% of pituitary tumors are very, very fibrous. It's almost more like a meningioma. And in those cases, you really have to be able to dissect around the tumor, not just work inside it and peel it out. I think that's one where I think without the wide exposure in the endoscope, it's going to be much more difficult. But I think the concepts there are far more important than anything else. And I applaud you for, I think all of us could learn from that.
Shekhar?
I echo all the sentiments and philosophy which Paul just reiterated, and I think we are really uh, happier using endoscope only for one reason, that it gives you a better opportunity to sort of visualize. I think the kind of angles you can get with microscope, even with a speculum in place, are something which I think you can do. But I think we find it much easier if you can have something which you can move. And beyond that, I think all the concepts are absolutely valid for endoscopic surgery as well.
Dr. Yadav, what do you think?
Excellent, sir. Excellent concept. Nothing more to say, but I think for us, for small lesions, using microscope was all right, but we were very scary to remove very large tumor with the microscope. But for you, I mean, the concept is excellent, and you can do, I have said, anything because of your expertise. But larger lesion, microscope is difficult. Endoscope gives us better view. Therefore, under vision we can remove it better. This is what I want to say. Excellent, sir.
Professor Sarvender. Unmute. Unmute,
Sarvender.
Yes. I agree with my other colleagues but the kind of experience, Professor Goel, you have, I think other people may not have this kind of experience, and you have been doing since ages together. And in this situation, I think for the younger generation, I think having a good visualization that will come handy at the expense of those who have less experience, because they would be able to remove better tumor in case they visualize it better. And I agree with other people that endoscope, once the things are under vision, then the radicality of resection can be ensured, and even the safety of the patient can be ensured. So in such a large lesion, it won't be possible for a routine neurosurgeon to excise these kind of lesions with such extensive spread through a small corridor. So I think it's basically based on the experience of individual surgeon, either with endoscope.
Paul, you brought out the issue of fibrous tumor, fibrous pituitary tumor. I must say that fibrous pituitary tumors, firm pituitary tumors are extremely rare. And it is, I have actually, I have got tumors which are extending right beyond corpus callosum and all. These tumors are soft, but they bleed quite a bit, but they are soft. It is extremely rare to have a fibrous tumor. You have fibrous tumor in prolactinomas, which have been drugged by cabergoline and things like that. Other than those, it is very, very rare to have a fibrous pituitary tumor. But I will take that point and I will not argue much on that. And I hope you like the concept of diaphragm, which we introduced 20 years ago. And I have no doubt in my mind, whether others have controversy or not, this concept has revolutionized. Otherwise, transcranial surgery was done right, left, and center by everybody, no matter how senior or how junior you are. Transcranial surgery for tumor which is going just suprasellar was transcranial indication of transcranial surgery. And now I have told you that I have no indication for transcranial surgery in pituitary tumors for a very long time. So this is how I have changed with my understanding. So let me go to the next pathology. Now, trigeminal neurinoma, I know I don't want to go too much, but I have got, even in this was published in 73 cases in 2003 with my concept of interdural, that these tumors are interdural in nature and they are in the lateral wall of cavernous sinus. You come from here, open the dura and start debulking. In exactly 5 minutes, you can start debulking these tumors. And even my recent concept is many of these intracranial component is also interdural in nature. So I introduced this concept in the year 2000. And also we were the first to indicate that these tumors arise in the region of Gasserian ganglion, and then from this origin they grow either anterior or posterior. And you will be surprised to know this article was the first as a series to mention that you can preserve the trigeminal sensations, and the success of operation is if you have improved the trigeminal sensation. This fact was never discussed in the literature as a series. There were only isolated case reports. So this concept that these tumors are interdural in location, even in large number, this posterior fossa can be interdural in location, according to my concept, has completely revolutionized. So in 1995, I described infratemporal fossa route to these tumors without craniotomy. Open the dura and remove this tumor. You can see this infratemporal interdural route on the basis of understanding that these tumors are interdural in location. And in 1995, I removed this tumor without opening the skull, you can see. And this is another tumor where it is going in the posterior fossa. You see posterior fossa and without opening the skull. Now, of course, you can do it with operating from the nose without opening the skull, but I had done infratemporal without opening the skull. I now for this, and this is another tumor which I had done by infratemporal fossa. Now my strategy is a little different. For these kind of large tumors, I come from lateral, open the dura and work within the tumor, and then you see these tumors in 1991 were different cup of tea, removal in 2 stages from one posterior, one lateral, and these kind of things were done in 1992. But then this concept of dura came. We started doing with larger exposures, extensive exposures. And in 1996, we were doing like this. But now I don't do all these things, even just do a smallish, this is my exposure, splitting of the temporalis, make a small exposure, open the dura, open the lateral wall, work within the dura, and any size of tumor I can remove with this basal subtemporal exposure, quick time, and in beautiful, as I mentioned, I had published 73 cases. My experience is now 300 cases and beyond. And I'm recently in this Corona times, I'm compiling and my article is almost set to be submitted. So this is the tumor, lateral exposure, lateral exposure, lateral exposure. So I have got hundreds of these cases, and without doubt in my mind, there is no need for any other. And even tumors with extracranial extension, 2010, I published a series of 28 cases, are interdural. You see, these are also interdural. You remember this dural confines and work within the tumor. For your opinion on trigeminal neurinomas, Paul.
I agree. I think these are purely interdural tumors that should be approached through an extradural approach, whether you, regardless of the corridor. I think there are only a very few of them that can be addressed endonasally or transmaxillary, and those are usually the more anterior, so V3, maybe extend down into the infratemporal. If they're purely in Meckel's cave or going into the posterior fossa, I do like a lateral orbitotomy incision. It's a very direct corridor. It's again a long line, but I don't think anyone can argue with a middle fossa approach like you've chosen. It's clearly the standard approach for these. But I think again, what you're pointing out is what's more important is understanding the location of the tumor and what it has done with the nerves. And I agree also that most people don't pay enough attention to preservation of a nerve function in these tumors. We ignore trigeminal function, but it can be devastating for patients. If you cause them long-term pain, you cause corneal problems, you can affect their masseter function, which even affects their appearance. So I think preserving the trigeminal nerve is as important as any other nerve. And so I think, again, learning from your experience of the understanding of the location of that tumor and preserving its function is critical.
Shekhar?
I think I agree with you. I have no experience of endonasal approach for trigeminal schwannoma, but this is something we were hoping to hear Paul from Paul. So maybe he can tell us if he thinks that it has any value at all.
I do. Again, I think it's only probably the V3 tumors. I don't think there are that many of them that can be accessed endonasally or that it's a good access. But I think the V3 or the anterior Meckel's cave tumors are the ones that are most useful because those are the ones where we're landing directly on the tumor and we're taking advantage of the tumor corridor. I can sort of show very quickly what I think are some tumors that can be accessed that way. You know, again, through this is a tumor turned out not to be a schwannoma, but certainly looks like a schwannoma, but it's both in the posterior fossa and in Meckel's cave. And here, this is the transmaxillary approach into the maxillary sinus and the sphenoid. And by doing that, we can expose, here's Meckel's cave. We're exposing the paraclival carotid artery, but here we've exposed all of Meckel's cave as well as all of the clivus. So here's Meckel's cave I can open, here's the clivus. I can open into the clivus, I can resect the clival portion of this tumor. There's the sixth nerve on the bottom of it. And then I can open Meckel's cave and I can resect the Meckel's cave portion. Here we see the fifth nerve on the floor of Meckel's cave. So by coming at the anterior part of this, I was able to preserve the fifth nerve as it runs along the floor of Meckel's cave here. So that's one example, but I think you have to understand the location. Here's a very large V3 tumor. Because there's so much infratemporal fossa, coming endonasally gives you access to that tumor. Again, it's the tumor corridor that we're taking advantage of. I think the important part of this, let me see if I can summarize it, is that they are largely V3 tumors. Yeah, I don't think I have that data right here, but it's largely V3 tumors. Here we go. I think this is the important slide. So these are all Meckel's cave and V3 tumors. Their more anterior tumors are the best ones. So it's, again, a select group of these that can be accessed, because if it is too far posterior in Meckel's cave, you're going to have all of the rest of the trigeminal nerves between the sphenoid and the tumor. So you'll be operating through trigeminal. But if it's coming through V3 and coming in the anterior part of Meckel's cave and down into the infratemporal fossa, then we have direct access into the tumor without having to manipulate the nerves. Otherwise, I think a lateral approach. So I would say that most tumors should be done through a lateral approach, but the anterior Meckel's cave and V3 can be done endonasally or transmaxillary.
Dr. Yadav?
Sir, I agree with you.
Thank you very much, my
Simple
dear
case.
Professor Sarvinder.
Professor, I agree with you. Your exposure, even open exposure, is just the size of a minimally invasive approach only. And secondly, I want to bring to your attention, there was one case of recurrent trigeminal schwannoma where the whole tumor had extended into maxillary sinus, and that we had removed through we did a Caldwell-Luck approach. We just defined and then entered directly into the maxillary sinus, and we removed the tumor. This was one of the case we did endoscopically.
Okay, so let's go to the next pathology. And I also wish that if somebody has question, he can put in question box. It will be, then we can ask the experts as to what they feel about the various questions that they are raised. Now, foramen magnum tumors. You see, Paul, I have seen some of your work, and you have even advocated coming from with endoscope, removing tumors like this. And it is, I had described in 2001, this midline posterior, instead of lateral and vertebral artery mobilization and all those things, I had described this lateral. And many of these tumors, as you know, they are not, you can remove from a smallish exposure by working within the cranial nerve. So this is the exposure that we had described in 2001. I want to show you my three cases of ossified foramen magnum meningiomas, which I have shown in Indian audience earlier. This is the tumor, and you can see it is completely bone, and you can see that it is encasing both carotid arteries. And this was removed by a very posterior approach working within the cranial nerves. This is another tumor. You see the carotid arteries within the tumor, and this is completely rock. And I will ask you if you can remove this tumor from front. And if you can, you can do wonders with endoscope. I know it, and I will like to have your answer. And I will say that to have the vertebral artery under control, to dissect it under vision, to dissect cranial nerves, and to remove I have a follow-up on 10 years in all these three cases of ossified tumor, which I published. You see, this is completely bone, vertebral arteries between the inside, and I remove this from a posterior midline approach. I want you would do with not only these kind of dangerous tumors, but even tumor located in the anterior foramen magnum meningiomas. Let me have your answer to this question. Paul first.
I think that there is a very small group of tumors that benefit from endonasal. The lower down a tumor is, the better it is for an open surgery. As soon as the tumor gets above 9 and 10, and certainly when it goes higher in the clivus, then your lateral corridor, no matter what maneuvers you make with removal of bone, even an extreme lateral, it doesn't get you past the nerves. As the tumor goes lower, down below C1 and C2, I can't get to it endonasally without potentially destabilizing the patient, so I would always do that from a lateral approach. But as long as it just goes to the top of C1, and especially if it extends superiorly behind and deep to the lower cranial nerves, or even deep to 7 and 8, I think those tumors are better endonasally. So lower is better from an open approach, higher is better endonasally. And of course, these all have to be midline. As soon as they're eccentric, then an open approach probably is better.
I agree completely with Paul's comments. I
Sarvinder?
think
Yeah, Sarvinder?
I agree with
Unmute.
Professor.
clival meningioma transcranial. But Paul, I've seen you present clival meningiomas in one of your presentations. Paul. Okay, so Dr. Yadav, you have any comment?
No, sir.
Okay, so we go to the Paul. Did you hear what I said?
I didn't. I think you cut out for a minute there.
Yeah, no, in one of the meetings, you were showing some clival tumors and meningiomas. So what are your indications for clival meningiomas and things like that?
I think midline between the vertebral arteries and again, above C1. As soon as they go below the tip of the dens, if I have to drill too much, I can drill the tip of the dens, no problem. But if I have to start removing more of the dens, then I worry about destabilizing the person. So it has to be pure midline and above C1.
Okay, so
and I apologize, Atul, I do have to go.
Just one, okay, one situation which I wanted you to see.
Okay.
Is one, and I was not, I did not want to tumors, but I have to tell you that I have this 96 cases I had published long time ago. Now I have a very, very big, huge experience with epidermoid tumors. And I must say that I will never agree if you are saying that I will do this by transnasal route, and that is a better route. And please pardon me if I say that I completely disagree with you. Epidermoid tumors are beautiful tumors by their color and by their pearl-like appearance, and they have to be removed by a, I had described supracerebellar route for these tumors. And this is the route which is the best and which should be adopted. And I had published pineal tumors, epidermoid tumors, and things like that. But an endodermal cyst also, I had written this article long time ago with 7 cases. Now I have got 22 or 23 cases. My feeling is these are not for endonasal route. Comments from you, my dear Paul.
I think it is more anatomic than it is the tumor type. I think that, yes, most epidermoid tumors are in the CP angle or they're eccentric off to the side. And most of those should be done through a craniotomy, supracerebellar or retrosigmoid. But there are very rare midline, purely clival epidermoids. And I think that those can be done endonasally. But I think that, yes, because when I do an epidermoid from a retrosigmoid, I still use an endoscope because that allows me to see around the corners and get a better removal. But there are a few very midline epidermoids that I would do endonasally. But the majority,
okay, what we'll do is, what I will like is, because you have to go, if you have some smallish video to show or something you want to show before you depart, or I will ask Shekhar to show some of his cases. You have something to show?
I think I've shown plenty. Okay. I'm happy, I guess, to show the chondrosarcoma, but let me see
quickly if you can show.
If you can show chondrosarcoma, we'll be very happy.
Okay. So let me share a screen for that.
I had several more pathologies to show, but you have to run away, my dear friend.
Yes, I apologize.
So I will make another section for you.
Duty calls. So here is a chondrosarcoma, typical petroclival. You can see the involvement of the carotid. And here's the sella, here's the clivus, and here we're working around the paraclival carotid artery into the petrous apex. So the tumor pushes the 6th nerve up, so we're working between the 6th nerve. This is what I call the medial petrous triangle. This is the back of Meckel's cave in the middle fossa. And the tumor really delivers itself by skeletonizing the carotid. I can mobilize it. You can see how, and I can even work around the carotid artery here into Meckel's cave. And the tumor has extended here into Meckel's cave. This is foramen lacerum right here. And by completely skeletonizing the tumor, I can mobilize it, mobilize the carotid artery, and take advantage of the corridor, this triangle into the petrous apex, and even remove this involved bone. Now we would use what's called a contralateral transmaxillary approach to reach even farther. Here's looking with an angled endoscope. There's the 6th nerve going into Drello's canal. There's the carotid artery. You can see we're working on both sides of it. But I have to be prepared to be able to coagulate or put a clip or something to deal with a carotid injury if I'm going to do this. And then here I'm resecting all the involved dura so that I get a removal of the petrous bone. Here we see the trigeminal coming in. So I've got a complete removal of this particular chondrosarcoma. Here's the post-op showing a complete removal. And here's another one. This is me make this a little bigger. Actually, up here, I got it. This is that very calcified one in the cavernous sinus. I think this is the one. Yes. So you see a very calcified tumor, very much in the cavernous sinus. And you can see the cell is pushed over here. I've completely skeletonized all the way out to the middle fossa. Here's supraorbital fissure and the optic strut. And this is like most chondrosarcomas like this, it has some soft portions, but here, the carotid artery is here. I have to split the tumor into 2 with a drill. It's so densely calcified here, and I don't know how you could get this access to the medial cavernous sinus from an open approach without working between the nerves. There's just some venous cavernous bleeding. The carotid is over here. So I can break this into pieces and I can dissect those pieces free from the cavernous carotid. So again, the carotid is pushed laterally and pushed anteriorly. So I'm taking advantage again of the tumor corridor. And this allows me to dissect free. This is using an ultrasonic aspirator, but you could use a drill as well. And again, here's the carotid artery. I can visualize it. I have it skeletonized, and now I can dissect behind it. So this is coming onto the lateral wall of the cavernous sinus between the cranial nerves. And this is working up towards the diaphragma, peeling it off of the diaphragma. The gland is completely pushed over because it's completely within the cavernous sinus. And then I'll resect the involved dura. Here we can see the basilar apex. We can see up towards the chiasm. There's the 3rd nerve behind it. And then, of course, nasal septal flap. And here you can see the post-op. You can see a nice carotid flow void and a complete removal. So it's challenging. I agree. You have to be able to deal with the carotid artery. But I do think if you select these, especially the more medial ones, and understand the tumor corridor, that they can be removed this way.
You know what, Paul? You mentioned about the 6th nerve. Nowhere in the literature, this is the first time we described that chondrosarcoma and chordomas consistently displace the carotid artery superiorly, and the relationship between carotid artery, they leave the company, and they again, you see that corridor. This is the, nobody had described, and nobody knows. That is why the 6th nerve damage is so common, because nobody knows that anatomy. I hope you will appreciate that you have, of course, taught us many things, but you have learned this new little trick while going from this webinar. What do you have to say? Give your comment.
Yeah, I mean, we talk about the lateral triangles to the petrous apex. I think this is the critical triangle from a medial corridor into the petrous apex. I think maybe it's arrogant to say, but I call it Gardner's triangle because I think it is the approach to this area. And I think that's what gives us access into there, is this anatomic triangle into the petrous apex.
So you can now say that this is a modification. This is, the 6th nerve displacement increases your triangle. And this,
absolutely, no question.
And this is the consistently identified feature in chordomas and chondrosarcomas, and this is what will increase the scope of your triangle.
Agreed completely.
So Paul, thank you very much for sharing your information and knowledge and experience and your work. I'm sure we are all very happy and proud to have you in our show. And this was going on for more than 2.5 hours. And I will, for the Shekhar will say some beautiful words about Paul Gardner, and I'm sure he's also, I can see that he's so happy. His face shows that his happiness. Shekhar. And you must know, Paul, that Shekhar is not a, he's a very, very well-known neurosurgeon, at least in the world of pediatric neurosurgery. He was a president of International Pediatric Neurosurgery Society, and he's the chairman of Endoscopy Society of World Federation of Neurological Surgery, and he's decorating several forums, and he's by no mean, he's a very well-known person in the field. And Shekhar.
Thanks, Atul. I think we have really seen some beautiful work, and I must congratulate Paul. I mean, though his work is well known, I think with time the experience has increased, your mastery over the technique has improved. I have had a chance to see you operate live in previous workshops. I think what is coming out very well, and something which I think the conventional neurosurgeons are finding it difficult to accept, are the concepts of the coronal plane in the endonasal surgery. And I think the very fact that several corridors are described transcranially to reach various things, uh, I'm very happy to know that there is already a corridor being named after you. And I think this is basically what Amin described as corridor surgery once upon a time. And I think probably there may be corridors which are partly endonasal, partly transcranial, but I think we are all doing this to improve our results, improve the life of our patients. And therefore, I think any new technique is welcome which can add to that value. And I'm really very happy to see the work, and thank you very much for sparing your time for us.
There is no question, Paul. You have stimulated many young people here in the audience and in our Indian context. And this is not just Indian. This streaming is going on far and wide. And this is also on neurosurgical TV, Shekhar. And there are many people all over the world watching, and your concepts and your understanding. And I am sure you have been able to teach many of us your concepts. Dr. Yadav is another very big star in Indian context, at least. And I'm very proud. And whenever I see him, the humility and you must sometime, Dr. Yadav, call Paul Gardner to your show, and he will be certainly, I will pull him somehow or the other and get him. And yes, Dr. Yadav, you have some words to say. Unmute
yourself.
Yeah, it has been excellent. I mean, I have seen Professor Gardner operating in live this thing, and I know his expertise. This has been excellent, and for all of us, great teaching. Thank you very much.
Thank you all very much. It's been a wonderful discussion, and obviously we all learned from this. So it's an honor to be here, and great to see you all as always. Hopefully in person sometime soon.
Thank you, Paul. Thank you. Bye bye.
Thanks, Paul.
Thank you.
And now, you know what, he was in hurry. I couldn't ask Sarvinder to say his defining words. Sarvinder
can summarize the day's proceedings, probably.
Sarvinder, please summarize the day's proceeding, because you are the future, and we look forward to, even, Dr. Yadav has been training the young people. Dr. Dev Pujari is training the young people. I have been not able to train him so much because of my style of surgery, I know, but I'm trying to little bit in my own way stimulate this young, very talented neurosurgeon, Dr. Sarvinder Singh, Sardar. Yes, Sarvinder.
So thank you, sir. Thank you for your compliments. And outright, I would say it was a very informative session. beginning with Professor Paul Gardner, who actually showed very good cases. Though lesion might be one, but there may be a many approaches to one lesion, and it was a great combination to see two people approaching from two different perspectives. Like Professor Goel, you approached by your method, by your technique, and what you have gained over the years. And Professor Gardner, who has perfected his technique by doing the same lesion endoscopically. But we could see that the end result by the two giants, you and Professor Gardner, I mean, though the approaches were different, though they might have merits, demerits, but it was good to see how person with different tool like endoscope or those with good microsurgical skill, they all can achieve the same objective. And with uh, with the changing times and with the technology that has advanced and the newer anatomical concepts that have come in, and the type of the anatomy means I mean the dural anatomy that you showed, and how it could be applied, and the people who in other endoscopic neurosurgery, how they apply these anatomical principles in the tumor resection. And it was wonderful to see the correlation of both the things. And it was great to hear from Professor Gardner, Professor from you itself, and Professor Dev Pujari and Yadav sir. And it was wonderful teaching experience.
So you know what, Shekhar, in our department, we have, as you know, Abhida is doing quite phenomenal brain work and phenomenal craniovertebral junction work, anatomical work. You have seen some of our papers published on white fiber dissection and other brainstem dissection, and several things being done. And she has got Vesalius Award and the Best Lady Neurosurgeon Award from the American Society of Neurosurgery. So we are having quite young, talented people who will take the, battle to the next level. Sarvinder is also working hard with endoscope, with cranial surgery. He is also very interested in bypass surgery, and he's also interested in several things. So these are my new pillars, and I have no doubt that Abida is a star of the next. She's already a star. You have seen Shekhar in various meetings. She's presenting authoritative work on fiber dissection. Authoritative work means absolutely out of the world work in various kinds of brain tumors and various kinds of things. And there is no question that these two stars of mine are going to take over the world of neurosurgery sooner than later. And they will take probably my name sometime in future. With Abida, you have to say something?
Whatever we have learned is through your teaching, through your concepts. And I think what we are learning is great. It's a different kind of neurosurgery from what other people are seeing, but it is a very beautiful school of neurosurgery that you taught us. And if by understanding those concepts, I think we'll go ahead and we'll go further. And you are there with us always, of course. And with you, we will go ahead.
So thank you very much, my dear friends.
सर मैं थोड़ा सा I would like to speak little bit. हिंदी में बोलूं तो और भी अच्छा है सर? नहीं. English, okay. So what I am saying, I have seen many things and very nice things so far. But what is most important for Professor Goel is that your innovative work and the work which has not described so far in the literature. So we are proud of you. Even we see the Western people that they have described this and that. So there are so many things which you think out of the way, and this is what is unique for you. Otherwise, what we do is somebody is saying something and we follow that, but you come with your own innovative ways, and that is the reason your team is doing the same work. Thank you, sir. Thank you very much.
Thank you, Dr. Yadav. And you must see our recent work on spine, on degenerative spine, on OPLL, on Hirayama disease, on central dislocations, on vertical dislocation, on several spinal issues, which is, believe me, complete revolution in spine surgery. Of course, you have seen craniovertebral junction surgery is complete revolution. So you are seeing some revolutionary things coming out, and there is no reason why I should not say proudly and why you should not say proudly. And I'm sure that we will be happy, and I am very happy and tremendously. And I have to tell you, Dr. Yadav, that what I am today and what I have been made is through my absolute great hospital, KM Hospital, which we have seen, which many people will not even like to enter. It is such a, not such a look wise. You go to any Western hospital, you go to University of Pittsburgh where Paul Gardner is, you go to Michael Lawton where his hospital is, you will, and then the next day you come to KM Hospital, many of them will fall unconscious. But we have made this into a different world, and we have shown the world that it is not the hospital, it is not the walls of the hospital that will make you, it is your dedication, hard work. And I will not hesitate in, complimenting Abida working on fiber tracks and all those things, and complimenting this, my dear Sarvinder, working in cadaver labs, difficult to get cadavers. He was hunting for cadavers.
I think
Dr. Goel's connection probably is not.
yeah, not.
Sorry, it went away, but with this, I would like to close the session with a parting small, nice thing from Dr. Dev Pujari.
Thank you, Atul, for this opportunity. I think your idea of inviting several authorities and educating people is extremely good, and I hope more and more people take advantage of it. And it's not only for young people. I think all of us learn something during all these sessions. We take small things away as well. And I am also happy that like you want people to open out to your new ideas, you are also opening out to others' new ideas, and exposing your own people to new ideas. And I'm sure this will work much better for a cohesive work in future. Thank you.
Thank you very much, and bye-bye. Take care. Bye-bye.
Bye-bye.
Thank you.
Bye-bye, Sarvinder.
Thank you.
Bye-bye.
Thank you, sir.